Good evening. Aikwans Stachel Hala. Heiska Kwans Ani Etla. In my broken Sinjavan, I said hello, everyone, and thank you for being here. On behalf of the Lafayette String Quartet and the Institute on Aging and Lifelong Health at UVic, welcome to the 15th Annual Lafayette Health Awareness Forum, the art of living in the time of COVID. I'm Shelagh Rogers, and I have the honor of being the Chancellor at the University of Victoria, home to the Lafayette String Quartet. I'm also a longtime broadcast journalist at CBC Radio. I'm delighted to be your host this evening. Hiluxun Kwans Anietla. I'm glad you are here, all 750 registered viewers and the socially distanced friends and relatives watching with you. To begin, we acknowledge with respect the Lekwungen people on whose traditional territory, the university stands, and the Songhees, Esquimalt, and Wasanic peoples whose historical relationships to the land continue to this day. We thank them for the opportunity to work and play and live on their territory and are grateful for their continued welcome. It's tradition at the Lafayette Health Awareness Forum to begin the evening with a short introduction and a musical selection from the four women of the Lafayette String Quartet. And so it is my pleasure right now to hand the proceedings over to them.
Good evening. I'm Pam Haiba-Aloni, cellist of the Lafayette String Quartet, and along with my colleagues in the quartet, Anne, Sharon, and Joanna, I want to welcome you to what is our first webinar of the Lafayette Health Awareness Forum. 15 years ago, we began hosting these forums on various topics after I had had a health issue that affected our quartet for a year. Through that experience, we deeply learned that what affects one of us truly does affect us all. With each year's forum, we've covered various health topics with expert speakers, and we can easily say that in no other year has the topic been more universal or our experience been more true than with this topic tonight. We are all affected by COVID-19 and have been since March. We are extremely honored and grateful to have our speakers, Dr. Bonnie Henry, Dr. Stephen Taylor, and Dr. Terence Tam, along with our host, Shelagh Rogers, for taking the time to be with us tonight. We know that we are not all together physically, but it is thrilling to know that we have so many of you with us here at this moment. Before I turn things over to our wonderful host, Shelagh Rogers, as is our tradition, we will play a short piece for you. We've chosen a scherzo from Beethoven's Opus 18, number 3, and 2020 happens to be the 250th anniversary of Beethoven's birth. Many celebrations of his music this year have been greatly altered due to the pandemic, so we wanted to share a little bit with you as we begin our evening together. You will notice in the piece a few stops here and there that are marked by a fermata. A fermata, or pause, and if you can believe it, it is also sometimes called a corona, is a sign to indicate for the players to hold a note for longer than is written. It seems to fit this year's topic well, as in this time of COVID-19, we can well imagine all of us can relate to that feeling of being on hold or in a fermata. Thank you for joining us.
Thank you to the Lafayette String Quartet for that spirited performance and for honoring Beethoven in a very big year, 250 years since he was born. Although the performance was recorded, fear not. The members of the quartet are attending tonight's event with us, and rightly so. In a moment, we will welcome Dr. Terence Tam, Dr. Stephen Taylor, and Dr. Bonnie Henry, who will all share ways of getting through this pandemic as we learn about the science that is leading us out of it. To begin, I have just a few housekeeping notes, which is as close to housekeeping as I like to get. To begin, as you know, as an audience member, your audio is muted, and only our presenters will be on video. This event is being recorded and will be posted to the Lafayette String Quartet and the Institute on Aging and Lifelong Health websites. The presentations will be followed by a Q&A session involving all the panelists. And during the presentations, if you have a question for a presenter, please feel free to add it to the Q&A section of the webinar and indicate to which presenter you are addressing your question. You will see the Q&A button on the bottom of your screen. Click it to bring up the text box, and our questions will be moderated, and we'll ask as many as we can. If someone had said last March that we would still be dealing with a pandemic in the fall and heading into winter and still be conducting so much of our lives online as we are tonight, I wouldn't have thought it was possible. However, here we are. 7 months later, my whole concept of time has flown out the window. It feels as though time has gone very quickly while plodding along at a glacial pace at the same time. And when someone asks me what day it is, I can't correctly answer except to say it's a day that ends in day, and it's often Groundhog Day. Many of us are feeling some anxiety in the day-to-day uncertainty. And what has helped my anxiety has been talking with a medical professional and listening to music. A parallel can be drawn between people in medicine and people in musical careers. Both continue to practice or have a practice throughout their careers. Both understand that silence may express as much as words do or musical notation, and both have to be consummate listeners. Our first speaker this evening has held down two equally demanding careers throughout his professional life. Dr. Terence Tam is an emergency room physician and has been the concertmaster for a number of orchestras. And of course, in medicine and the performing arts, the COVID-19 virus has had great impact. We're very fortunate to hear his unique perspective this evening. Dr. Tam's presentation is called From the Front Lines and Backstage, a Perspective on COVID-19.
Thank you, Sheila. It's such an honor to be speaking at this forum alongside esteemed colleagues, Dr. Taylor, Dr. Henry, and the Lafayette String Quartet. The last 6 months have been such an incredibly challenging time for all of us. We've been inundated with a huge amount of information about COVID-19 and how it has affected almost every aspect of our lives. Everywhere we turn, the internet, the radio, the news, conversations with friends and family, we are bombarded constantly by COVID. Nevertheless, my goal for tonight is to give a kind of behind-the-scenes glimpse into some of the challenges I and my colleagues currently face at this stage in the COVID pandemic, both from the perspective of my work as an emergency physician and also from the view of my work as a professional musician. In the emergency department, or the ER, what still tends to be on our minds much of the time is PPE, personal protective equipment. We've all heard about the PPE shortages worldwide, but it hasn't really been in the news much in recent months. Well, the bad news is that the shortage still exists. We are very careful about conserving our PPE, especially the N95 masks, which we use only in the most dire of circumstances. Sadly, the N95 is also our best protection from COVID. In an ideal world, we would wear an N95 all the time in the ER until the pandemic ends. Why all the time? Well, because there is a theoretical risk that every single one of the 20 to 30 sick or injured patients I encounter on every ER shift could potentially have COVID, whether they have any symptoms or not. Some studies have found that frontline healthcare workers had 3 times the risk of becoming infected with COVID compared to the general population. Imagine that infection spreading to other healthcare workers and inpatients, and now you have a hospital outbreak. I'd be lying if I said that I didn't have moments of fear and anxiety concerning this risk every time I set foot in the ER. Let me go into a little more detail. What I normally wear in the ER is the common blue surgical mask with protective safety glasses. I get a fresh pair of gloves for each patient I treat. However, the mask stays on most days for 8 hours straight. The truth is that even though I've mostly gotten used to it, my ears still ache several hours into a shift, and I'm constantly reminded by the tickle in the back of my throat that I've been breathing through the mask for longer than I really should be. And even after more than 6 months of doing this, it remains a challenge to not touch the mask with my hands to adjust it, risking the possibility of cross-contaminating either the mask or my hands. So that's my everyday uniform. What about when I have to examine a patient with symptoms that are suspicious for COVID, like somebody with a fever, cough, and shortness of breath? Well, I then go to my second level of PPE. That includes a water-resistant gown, a surgical mask with a protective plastic shield for the face, and gloves. It is crucial to put these items on in a very specific order and sanitize my hands before I start. After I'm done, I am even more meticulous when taking off each layer of PPE. I follow a very precise routine while sanitizing my hands between each step. Why go to these lengths? Because making a mistake while removing PPE actually increases my risk of exposure to COVID. Amazing, this double-edged sword, protective equipment that can actually harm you. The third and final level of PPE that we use is the one that involves the famous and forever in short supply N95 mask, along with gowns, hoods, and shields that give almost full body protection. We reserve this PPE mostly for critically ill patients, such as patients in cardiac arrest, who pose the highest risk of transmitting COVID. Now here's a dilemma that you might not be aware of. A patient in cardiac arrest needs immediate resuscitation, including CPR. Normally, everybody in the ER drops whatever they're doing and rushes over to help because every second counts. At least that's what happens in normal times. In pandemic times, resuscitation requires that we wear this full third level of PPE for maximum protection. Here's the problem. No matter how much practice our team has had, we lose valuable minutes because of the extra time it takes to put on this kind of gear. This is perhaps the most disturbing example of how a lack of PPE in the time of COVID has changed the practice of emergency medicine. Believe it or not, in 2003, I was unlucky enough to be also working in a Toronto emergency department during the SARS epidemic. In those days, there was no shortage of PPE, and I wore N95 masks all the time, along with an outfit that made me look like an astronaut and took sometimes 10 to 15 minutes to put on at the beginning of my shift. We now know the SARS virus was much more deadly and contagious than COVID, but I actually felt safer back in 2003 than I do now in 2020 because I didn't have to worry about PPE. What about physical distancing? Physical distancing has become the new dogma during this pandemic. But how is this possible in the ER? Well, basically, it's not possible, certainly not between doctors, nurses, and their patients. Of course, that's why we need PPE. But beyond PPE, we have gone to great lengths in an attempt to separate and prevent patients from contact with each other. My ER and many others have tried to physically divide the entire department into different areas, This includes an area for people with no COVID symptoms, an area for people with potential COVID symptoms, and a separate area for those with classic COVID symptoms. Think of it as separate emergency bubbles or cohorts, familiar terms these days. Another challenge working as an ER doctor is trying to figure out who might have COVID and who to test for COVID. The problem is that there is a long list of possible COVID symptoms that overlap with hundreds of other illnesses. The WHO lists 13 symptoms, and the BC Centre for Disease Control lists 18 symptoms. Most of these symptoms are what we call non-specific. For example, COVID can cause a fever, but so can 100 other illnesses. If a patient has even one symptom that could be attributed to COVID, I have to consider this in my assessment. This is more difficult than it sounds. In fact, every time I think to myself, this sure doesn't sound or look like COVID, I find that I have to go through a process of rethinking and reconsidering whether it may be more prudent to do a COVID test, even in what seems to be an unlikely scenario. Luckily, with the current increased capacity for testing, we have the ability and indeed a mandate to do more testing. I'm now going to change the channel, so to speak, and talk about my parallel universe. Yes, unfortunately, COVID also exists in my musical world, and with different but just as devastating an effect. I'll never forget how on March 12th, the Victoria Symphony was holding a dress rehearsal for a concert of Beethoven's symphonies, celebrating the 250th anniversary of his birth. During a coffee break, news spread quickly that basketball's NBA and baseball's MLB leagues had canceled their seasons due to COVID. Within another few hours, our own season was canceled, and so began what I call the beginning of the end of live music. All large gatherings were banned, everywhere. The Victoria Symphony, which has 45 full-time members and performs weekly to audiences of 1,000 people, was finished with not even a hint of a restart date. Some famous provincial health officer, whose name escapes me at the moment, had decided that in BC, no gatherings of more than 50 would be allowed until either a COVID vaccine became available or herd immunity was achieved. We were shocked. It became clear that live music concerts would be on hold indefinitely, perhaps one of the very last things to recover from the pandemic. Yes, many musicians and music organizations adapted by moving to online streaming of what we now call virtual concerts. I recently looked up a definition of the word virtual in 2020. It means existing or occurring on computers or the internet. So, we do so many things involving the internet every day. Why not just add these virtual concerts to that routine? The most obvious answer, one that most people understand, is that music just doesn't have the sonic or emotional impact coming from a smartphone or computer with a tiny screen and even tinier speakers. What might not be as obvious is that live music does not only involve the musicians. It involves a very tangible and essential connection between the musician and their audience. A physical connection, not a virtual connection. This is what makes us performers. We can't be real performers if there is nobody to perform for. After all, that's what I trained for much of my life, to perform for an audience. The current restrictions brought on by COVID have totally dismantled this reality, potentially for a very long time. When the lockdown happened, I left my violin in its case untouched for months. I couldn't bring myself to pick it up. Even though I missed it, I somehow felt like it would be an exercise in futility with no concerts happening. When I did finally dust it off, it was to prepare for a virtual concert to celebrate Canada Day. The CBC had put together a group of 30 of my colleagues from across Canada to perform a premiere of a work conducted by famous Canadian conductor Yannick Nézet-Séguin. Although I was honored to be part of such an important project, it was a truly bizarre experience to sit in my studio by myself, record only my violin part, while watching a pre-recorded video of the conductor, and then to email my recording to the producer, who put it all together with the other 29 emailed parts to produce, you guessed it, a virtual performance. We performed together without having performed together at all. As intriguing a project as it was to be involved with, I was left with a somewhat empty feeling afterward. I thought to myself, this can't be what music is going to be like. Fast forward to today, October 1st, where the Victoria Symphony has now established a virtual season of recorded and streamed concerts to happen every 1 to 2 weeks. Because the Symphony has to maintain social distancing, we can still only fit about half of our group, or about 20 players, on a stage to record and rehearse. The first rehearsal 2 weeks ago was extraordinary. Extraordinary to be back with friends and colleagues and making music in person. But also extraordinary in how difficult it was to communicate with and hear each other over what seemed like huge distances. Days later, we successfully recorded our first virtual concert. Again, with a mixed bag of feelings. So happy to return to work, to share this kind of musical intimacy with each other again, and yet to perform for an invisible audience. What a strange feeling. I don't think I'll ever get used to it, nor do I want to ever get used to it. It's not all doom and gloom. I do have hope. Literally every music lover I have talked to is chomping at the bit for live performances to return. There is more enthusiasm than ever for the medium of live performance. So many people are feeling an emotional and spiritual void because of our current situation. Some of my less optimistic colleagues have forecasted that this pandemic might change the world of live concerts forever. I respectfully disagree. I feel that just as we all know deep down that we will be able to hug each other again one day, we will also one day have live music again with live audiences in the same space. Hope also exists in my ER world, a world which can never be virtual. A vaccine is on its way sooner or later, in large part due to incredible cooperative and international efforts. And despite the despair and fatigue that I witness in many of my patients, I am also encouraged when I see evidence of resilience and determination to survive over the long haul. Months ago, I regularly would hear patients bitterly complain about having to wear a mask in the ER. Now, more often than not, they sheepishly apologize for having taken their mask off, perhaps needing a break after a particularly long wait in the ER. Patients used to react with anxiety and almost panic when I suggested that we do a COVID swab. Now, more often than not, they almost expect that it might be part of their ER visit. These seemingly small gestures from patients remind me that we are amazingly capable of adapting to adversity, even in a global crisis. These are some of the important things that have helped to lift me out of my own moments of despair over the past 6 months. Faithful music lovers and patients who show strength even when they are vulnerable. These people help me to dig deep and find my own strength to stay positive and to persevere. Thank you for this opportunity to share some of these thoughts with you.
Thank you so much, Terry. What a wonderful gift to have your perspective. And if we thought the stakes were high in the emergency room on a normal basis, I can't even imagine how they are now. But you've given us a great insight into that. I want to thank you also for hope, and then the belief that we will be back together again, enjoying the music. And in the meantime, so many thanks to musicians and performing artists like you who are getting together, distanced, and performing for our greedy hearts that are so in need of that kind of feeding right now. Thank you very much, Terry. I think one of the wisest things that I've heard over the course of the pandemic is from my friend Sudhir Nair, who's a professor of international business at UVic. And in the spring, he said, this is not a bump in the road, it is the road, and we have to learn to walk on it. There are a lot of paradoxes in this pandemic. We are apart together. We are in this together, though farther apart. We're connecting virtually, as Terry said, like never before, yet we're more isolated. The pandemic has created uncertainty about when we'll be able to see each other again in person, when we can gather as families, romantic partners, friends, and hug each other. Our next speaker is Dr. Stephen Taylor. Dr. Taylor is a professor and clinical psychologist in the Department of Psychiatry at the University of British Columbia in Vancouver. His work focuses on anxiety disorders and related clinical conditions, and also on the psychology of pandemics. He's the author of more than 300 scientific publications, more than 20 books, and his most recent book was published just a few weeks before the outbreak of COVID-19. It's called The Psychology of Pandemics, Preparing for the Next Global Outbreak of Infectious Disease. We're so very fortunate to have Dr. Taylor with us, and Dr. Taylor's talk is titled The Psychology of COVID-19.
Thanks very much, Sheila, and thanks everyone for inviting me. I've got a PowerPoint presentation. One second. I have to share screen. If I had my 12-year-old son, he could do this for me, but he's not here. Okay, so I'm going to talk a bit about the psychology of COVID-19, and it's based on the research that we've had underway now for since the beginning of February. But, oh yeah. So I knew a pandemic was coming. We all did. We just didn't realize it would be coming so soon after the publication of this book. Many people asked me why I wrote it. I started working on it in 2018, which turned out to be the centenary of the so-called Spanish flu. And around about that time, there were a lot of interviews with virus experts, epidemiologists, talking about that pandemic. And I got interested in that because my background is in anxiety disorders and health anxiety. And the more I looked at the whole issue of pandemics, the more I realized that psychology was hugely important, and no one had ever put it together in a book. And we used the research from this book to develop our work on the psychology of COVID-19. So what I'd like to talk about in the brief time available is to illustrate why psychology is important for understanding and managing pandemics in general, and COVID-19 in particular. I want to compare COVID-19 to previous pandemics, a lot of similarities, or there are some interesting differences. We'll talk about our COVID stress study. So we're trying to understand patterns of emotional behavioral responses to COVID, and with the goal of translating these findings into treatments, for example, and other things. Talk about mental health resources. And I want to finish off by speculating about what life might be like in a post-pandemic world. Now, notice here, I don't say a post-COVID world. I say post-pandemic because we know the pandemic will end, but we don't know whether COVID-19 is here to stay or not. Psychology is important because if you look at the contemporary ways of managing pandemics, they all involve people agreeing to do things. So health authorities need to communicate in a clear, reliable, consistent fashion. And if we don't believe what our health authorities are telling us, we're not going to follow their advice. People have to agree to give up little freedoms in their lives. They have to agree to wear masks, to socially distance, to not go to parties. And of course, when a vaccine is available, we have to agree to be vaccinated. So whether people agree to follow these guidelines or not has a huge impact on how these pandemics are managed. So you can see that's one aspect as to why psychology is important. The other reason is that for some people, they're experiencing psychological disorders triggered by the pandemic. It could be depression or anxiety or obsessive compulsive disorder, or in some cases, post-traumatic stress disorder. And of course, we're finding that people with pre-existing emotional behavioral problems are finding that they're being worsened during the pandemic. There has been an increase in substance use disorder, particularly among people with pre-existing disorders, for example. There are many similarities between COVID-19 and previous pandemics. The rise of racism, unfortunately, that's happened in every pandemic that I've studied. There's been a rise of racism, that people are looking to find someone to blame to try and make sense of what is happening to them. So that's one of the biggest challenges that we need to think about in managing a pandemic, managing the social disruption that this happens. Panic buying has occurred in every previous pandemic that I've looked at. And interestingly, now we're going into in some countries, a second wave of the pandemic, and that's bringing with it a second wave of panic buying, including our good old friend toilet paper, which is a target for another wave of panic buying. People ask me, what surprised me about COVID-19 versus previous pandemics? And my answer is toilet paper. I knew there'd be panic buying. I was just a little surprised that people would be latching onto toilet paper as a thing to buy. Sporadic looting, but by and large, what is seen in pandemics is a rise of altruism, people coming together. That is more common than looting and bad behavior. Rumors and conspiracy theories have been a staple of pandemics. And interestingly, the conspiracy theories that we're seeing this time around are similar to ones we've seen previously. For example, during the Zika virus pandemic, there was a conspiracy theory that the virus was manufactured in a lab and somehow got loose. And we're seeing that with some of the conspiracy theories around COVID-19. Mask rebellion, it's happened now and it happened a century ago. Talk about that in a second. Vaccination refusal has been a problem in past pandemics as well. And profiteering. So on the left, 1918 was a newspaper ad for McGregor's Final Scotch. And the slogan there was a real tonic for the flu. So they were trying to cash in. Nothing much has changed. In 2020, Coca-Cola put this big ad in Times Square in New York, trying to pair their product with social distancing with the slogan, "Staying apart is the best way to stay united." Panic buying in 1918, people were rushing to pharmacies and drugstores buying Vicks vapor rub or other things they could rub on their chests to ease their breathing with the idea that this was a useful remedy. And of course, in 2020, we've seen panic buying of toilet paper, or if you live in the United States, it's panic buying of guns and ammo. The mask rebellion in 2020, not much different. In 1919, in various parts of the United States, for example, San Francisco, there was something called the Anti-Mask League that was formed. The objections back then are similar to those today. The people in 1919, or some of these people, said that they didn't want to wear masks because they were uncomfortable, they didn't think they were effective, and they thought they were a violation of their civil rights. Does that ring a bell today? The same kinds of ideas being raised. In 1919, the Anti-Mask League just fizzled out. But here in COVID-19, it's a different pandemic in that it's a pandemic in the era of social media and digital interconnectivity. So it's easier for people who believe in conspiracy theories or have anti-mask attitudes to get their message out on a broader scale. In 1919, that wasn't really possible. So here you can see that the same resistance to wearing masks, the same reasons 1919, 2020. It's interesting if you ask people, what is it about wearing masks that they don't like? Finding their motivations can give you a clue as to how you can improve the uptake of masks. If masks are uncomfortable or overheat, well, maybe design masks that are more comfortable. If a person doesn't like wearing a mask because they don't like being forced, that's a phenomenon called psychological reactance. It's like an allergic reaction to being told what to do. When my son was 3 years old, I remember one time I told him to clean up his room, and he said to me, "You're not the boss of me." And I looked at him and I said to him, hang on a minute, I am the boss of you. Go clean up your room. Psychological reactions is like grown-ups saying, "You're not the boss of me. You're not telling me what to do. I'm not going to wear this mask." And the more you get into arguments with them, the more they think of reasons for not wearing a mask. So getting into fights and arguments with these people who have this allergy to being told what to do, is not a way to succeed. Another approach might be to say, well, I understand you don't like being forced what to do, but wearing a mask is the right thing to do for your community. So not directly confronting them. Our COVID stress study was funded by the Canadian Institutes for Health Research. We were really fortunate in a way when all the labs were closed down. For example, all the research labs at UBC were closed down at the early stages of the pandemic. We got up and running because we had a virtual internet-based assessment platform in place. And we're trying to understand the extreme reactions. We're finding evidence for a COVID stress syndrome, so the one end of the continuum, and what we're calling a COVID disregard syndrome. It's not a syndrome in the medical sense of the word, it's rather a collection of psychological features that hang together. And roughly we're thinking 10%, 15% at each end of the continuum. So let me explain what I mean by these syndromes. The disregard syndrome, these are people who believe the threat of COVID to be exaggerated. They see themselves as being robust in their health. They see themselves as being at low risk for infection. And they think that if they got sick, it would be just like a little bit of flu. And you can think of famous political leaders who would fit into this syndrome. These people tend to be non-compliant with social distancing. We asked people with this syndrome, would you be okay going out to a party if you were sick with COVID-19? And they go, oh yeah, that'd be okay, no big deal. And they're more likely to refuse a vaccine. These are a very challenging group of people to engage, and they actually spread the virus. At the other end of the continuum is what we're calling COVID stress syndrome. And this infographic shows the 5 features of it. These people are very frightened about getting infected. They are xenophobic. They're frightened of foreigners. They believe that strangers are somehow spreading the virus. They're having traumatic stress symptoms, that is nightmares about the pandemic. And they're compulsively checking the news, social media, checking their bodies, calling health lines because they're worried and they're seeking reassurance, and also very worried about the personal socioeconomic impacts on their finances and jobs and so forth. I'm switching gears a bit. Mental health services is a huge issue, and we're starting to do some research on this, developing mental health platforms. We know from research available so far that these online resources are helpful, but are they sufficient for severe mental health problems? Maybe not. And we need to target the interventions towards specific problems. We need to develop resources specifically for the COVID stress syndrome, and we need to meld these in with programs that deliver financial aid to people. Because remember, being distressed about COVID-19 doesn't necessarily mean it's all in your head. You could have some very, very strong reasons for being frightened of the socioeconomic impact or personal impacts of COVID-19. I'm going to wrap it up by talking about some ideas about life in a post-pandemic world. So are we going to go from this to this? Well, the answer is, yeah, of course, we're doing this already. This is from Wuhan in China after lockdown had been rescinded. So these people were getting out to a massive pool party. If you look really hard, you'll see that actually no one in there is wearing a mask and there's no social distancing. And what that gets at the fact is that people are generally robust. So we do know from natural disasters that maybe 10% of people will develop severe psychological problems, post-traumatic stress disorder, for example, or depression. And we know from SARS that many people may develop post-traumatic stress disorder. And in COVID-19, we expect that a number of people will develop or have a worsening of OCD or germ phobia. However, there's some good news to this. We know that most people are resilient to stress, that people are actually stronger than they think. And I think some people are learning this. And the news gets a little better still. There's evidence of post-traumatic growth, and that is growing during adversity. And we've been doing some research on this. We're finding that nearly half of our respondents, our adults in our sample, say that there has been some silver linings of positive things from COVID-19. For example, people are reporting, well, they better appreciate friends and family. They have a greater compassion for others. They see themselves as more resilient to stress. And some people are reporting deepened spirituality. So it's not all bad news, although COVID-19 is a very serious disease and many people have been sick and died. There are some silver linings, and some people are coming out as better human beings as a result of all this. With that, I've finished up. Thank you very much.
Stephen, thank you very much. And I have to say, I wasn't expecting to laugh out loud quite as many times as I did, but your remarks about toilet paper were fascinating. And thank you also for drawing such interesting parallels to the 1919 pandemic. I'm also glad that you ended in hope. Glad to know that there is, in spite of a rise in racism, which we are all seeing, there's also a rise in altruism and a growing appreciation of friends and family. I think that is something that we had taken for granted before, a time when we couldn't see them, even if we didn't want to. So thank you very, very much for your presentation. Fascinating. Dr. Stephen Taylor. Well, little introduction is needed for our final presenter, the Provincial Officer of Health for British Columbia, Dr. Bonnie Henry. Her calm and steady leadership has kept us calm and steady too. She comes onto our radios and TVs and computers, into our homes, offices, our home offices for that matter, our cars, and we feel we know her and we trust her to keep us safe. Dr. Henry is also an author of this book, most recently, Soap and Water and Common Sense, The Definitive Guide to Viruses, Bacteria, Parasites, and Disease. And not surprisingly, it hit #1 on the best-selling nonfiction book lists this spring. The book flying off the shelves and the resonance of her daily news conferences are testament to her ability to communicate often challenging material in a compelling, companionable, and compassionate way. We're grateful to Dr. Henry for her knowledge and wisdom, her steady assuredness, her humor and humility. I have to say, I think of you every time I wash my hands, and now with my special dish towel, every time I wash the dishes. And we are honored that you've taken the time to be with us, Dr. Henry. Dr. Henry's presentation is titled, Be Kind, Be Calm, Be Safe, Life in the Time of COVID.
Thank you so much, and thank you for the privilege of being with you all tonight. It has been a challenging year for all of us, and many people say unprecedented, and many people say things like, who thought this would happen? But you can tell from Dr. Taylor's presentation, and actually many of us thought this would happen. As a matter of fact, we probably knew this would happen. And what I thought I would share with you tonight is a bit of the story of where I came from and where this happened, and how we responded here in British Columbia, and then where we are now. So most people pinpoint their recognition of this pandemic to March, but I can tell you that the first time it came into my consciousness was in December, and actually it raised some of my post-SARS anxiety on December 31st, when we heard a report out of Wuhan, out of China, that said there was a cluster of atypical pneumonia, which is medical code for a bunch of people getting sick with infections in the lung, and we're not sure what caused it. And as Dr. Tam will remember, that was how the SARS outbreak in 2003 started. And I also had the misfortune of being working in the city of Toronto. I was the Associate Medical Officer of Health with one of my dear friends and colleagues, Dr. Sheila Basra, at the time of SARS in 2003. And that is what happened then. We had reports out of China of a small cluster of atypical pneumonia. And the central government said, oh no, it's chlamydia pneumonia, nothing to worry about, nothing happening here. That was something that we heard again in January of 2020. And by the time in January of 2020, those of us who follow these things around the world knew that in China, they had the best researchers in the world into influenza, into SARS, into coronaviruses, because they had learned a lot from the 2003 pandemic, when China had concerns with sharing with the world. So my post-SARS PTSD, which I absolutely have, started causing me anxiety and sleepless nights early in January. When we watched the progress, we knew that things were not the same as our usual alerts that we were having. And this is not my first pandemic. It's not the first pandemic that we've been through here in North America in our lifetime. Certainly SARS was a pandemic on a smaller scale, but we had an influenza pandemic in 2009. And then, of course, we had a lot of concerns around Ebola in West Africa, and particularly in 2014. And just to say that these are all things that fed into the consciousness of people who do work like I do in terms of preparedness for pandemics and infectious diseases. We recognized early on, and having worked in Ebola, having worked in some of these pandemics before, I recognized and I knew, and as did many others, that words were important and communication was an important part of our role in helping people get through these crises. We recognized that to support in communities going through crises, we needed to feed into the altruism, the important connections that we had together. As we moved into March, we watched with bated breath and some trepidation what was happening in China, and it became clear that this virus was spreading. I think the positive things that came out of it were that we had a viral genome quite early on, and as Dr. Tam also talked about, the ability to have a test put us leap years ahead to where we were in 2003. And the BC Centre for Disease Control lab here in British Columbia and other labs across the country were able to develop tests that allowed us to test for this virus early on. And if we go back to January and February and March, we were able to find people very rapidly here in BC. We recognized that we had travel patterns that would put us at risk of this virus coming into British Columbia, and we brought the health system together as quickly as we could. The words that have come into our lexicon since that time, we talked a little bit about them earlier today, things like PPE. Who would have thought it? The first time I used the term PPE in a press conference, somebody asked me, what is that? And I thought, oh dear, we're going to have our challenges. And we knew early on that this was going to be one of them. When we got to March, there was a whole series of events that happened in a very short period of time. We had watched the virus escape from China. We knew that that was happening. We knew that it was spreading around the world. We knew that it wasn't as infectious as influenza, but it was easier to spread than viruses like the first SARS virus. We knew it wasn't as severe as the first SARS virus, but it was more severe than influenza and could cause illness in a lot more people. And as we learned more and more about the virus, we realized that it actually spread before people showed signs of symptoms, making it even more challenging to find them and to find people and to prevent it from spreading in our community. And I think that's the thing that we now are facing, the fact that this virus is a community spread virus, which makes it different from some of the other ones that we've had to deal with, particularly SARS-1, which was mostly confined to healthcare settings. So once it's in our community, we all have had to take measures that would support preventing transmission. But if we go back to those days in March, when we saw what had happened in China, and when we saw what was happening in some other parts of the world, particularly at that time in northern Italy. And here in Canada, we had had increasing numbers of cases. We had introductions from China. We had introductions from Iran, which was a very unusual event and triggered a lot of concern from us in public health and made us take that leap of ratcheting up our preparedness as a province. We also had the introduction of this virus into some of our long-term care homes, and it became painfully and tragically apparent how severe this virus could be when it got into communal living settings with people who were very vulnerable to having severe illness and dying. And I think that is our biggest tragedy in this country so far, has been the transmission of this virus in our long-term care homes and the effect on our seniors and elders, people who are so dear to us as a community because of their history, of the culture, of our language, of our being as a community and of families and people. So when we started to see what was happening in other countries around the world, it became very apparent that people were dying from COVID when health systems were being overwhelmed because they could not be cared for properly. Healthcare workers were being infected because they didn't have access to PPE, but also because they didn't have time between the myriad numbers of people who were coming in with these illnesses, and there were so many people sick that they were self-contaminating. We also knew that when systems became overwhelmed, it affected everybody else in the community too. And you couldn't get the care you needed for the car crashes and the heart attacks that were also happening. So in March, we watched what was happening around the world. We knew the potential that it could happen here. And we were starting to see increased numbers of cases that we couldn't link to travel or to somebody else. And in our province, a number of the things that occurred were people coming in from Washington State, and the tragedy of what happened in Washington and in the United States, where testing had been problematic. We also had the unfortunate event of a very large medical conference in the city of Vancouver. In the end of the day, it turned out there were 87 people who were infected at that conference and who spread infection around our province, and another several hundred in other provinces and around the world. That happened from a very small, probably too small, we know from genomic testing, introductions during that conference at that very critical time. So that day in March, when we made those decisions to, and I will say that I don't call it a lockdown, because we did not actually lock down as many other communities did, but we did at that time put in restrictions that meant that anybody who traveled outside the country had to quarantine for 14 days when they came back. And that essentially made it a challenge for people to travel. And we did that on the day before March break. And the reason for that was because we were watching what was happening in other provinces. And I had been meeting regularly with my colleagues across the country, and we heard from Quebec, whose March break had been 2 weeks before ours, that people were coming back and getting sick. And they often were coming back from other European countries, so Italy, but France in particular. And that was spreading in their community. We recognized that what was happening in Washington State was going to affect us. And I think this was a challenge that we had not recognized in many ways in the past. The fact that what happens in China affects us, what happens in Italy affects us, what's happening in Washington State affects us in profound ways. So that day that we put on restrictions on travel, and sorry, Dr. Tam, restrictions on gatherings. At that point, it was 250, but it very quickly became clear from what we were watching around the world that when people were together in close concert, and I use that term, when people were together indoors in particular, and when they were close to each other, and when they were participating in such important cultural things like music, that this virus could spread and it could cause irreparable damage. So we did stop, put in restrictions on gatherings, and yes, they went down to 50. We stopped some of those important things in our communities where people got together and gathered indoors, like restaurants and bars. We had to stop those situations where people were coming together and couldn't maintain a distance, like nail salons and hair salons, and all of those challenging things all at the same time. Trying to put in measures that we knew or that we hoped from watching in other places would help keep people apart, well enough apart that sick people couldn't transmit to well people till we could figure things out. And I recall vividly the day that we put those on, those restrictions in place. And it was not lost on me that the unintended consequences, both positive, and there's a few of those, as Dr. Taylor mentioned, but primarily the negative unintended consequences of what was going to be put in place, that we needed to pay attention to those and measure those. And I'll come back to that in a minute. But on that day, I knew it was incredibly important for us to play to people's altruism. As we've heard, when you're in a crisis, there are many things that people do. Some people go into prevention control mode, and they become very anxious about everything. Some people are avoidance. Some people, it's the flight mode. Flight mode myself. If there had been any place in the world that I could have run away to, I would have. And these were things that I knew were incredibly important. And what we needed to do was to play to that altruism that is in many, many people. The words that were flowing through my mind as we went to that press briefing that day were about kindness. And that came from, I had been doing an interview with a student reporter, and he was telling me about how some kids in his school who were wearing masks were being picked on and made fun of. And we talked about the importance of kindness, the importance of recognizing that it comes from that feeling of kin, that we actually care for each other. It's not about being nice, it's about that deep understanding of each other as fellow people, fellow kin, and that is how we were going to support each other. The other word that came to me was calm, and that was about the anxiety that we were all feeling, and the fact that when we are anxious, when we're going through a crisis, when we're thinking about those others and the blaming, it's very easy to jump to conclusions, and we cannot always know another person's story. So the idea of calm is about how do we take a deep breath, take a step back, and recognize that we are not always aware of everybody's circumstances. And finally, the word safety, because that's what we all wanted. We all wanted to be safe in our community, to be safe in our work, to make sure our families were safe. And we can't have safety unless we only need to do the things that we know can protect ourselves as individuals, but also unless we have the kindness and the calmness that we have as a community to support each other through a crisis. We need all three to be safe, and we needed all three for us to get through this storm. I've said many times that we're all globally now in the same storm, but we are not all in the same boat. And we need to recognize that for some people, it's a desperate attempt to stay alive, while others are in a luxury yacht and are maybe not feeling this at all. As we've watched this virus spread, we know now that there are many things that are that we can do individually and collectively, and we know it works. So what happened in March when we put in the restrictions that we put in, we didn't know when we were looking at the epidemic curve going up how long it was going to last or how bad it was going to be. And the level of anxiety, particularly in our healthcare workers in hospital, who knew that the essential workers were so many people in our community, like grocery store workers were so important to us. Yes, I still don't understand the run on toilet paper, but it was one of the things we all experience. People that we know that pick up the garbage, the people that keep our parks clean, all of those important pieces in our community that are essential. The fact that we need truckers to bring the food in from farms and from other places. The fact that essential workers. So we did manage to flatten our curve here in British Columbia very quickly and effectively. And for some people, there was an increase in skepticism that we had all done way too much. But I think we only need to look around the world to see that it is a challenging time to find the right balance. And when I think about the ethical principles, and much of the work that I've done in the past is looking at the ethical underpinnings of the work that we do. And we've done a number of documents around the ethics of how we're going to respond to this pandemic. And the trick really is, as one of my colleagues said, to put in just enough. But it's very hard to know what just enough is. And when you don't know a lot about a new crisis, a new virus like this one, I felt and we felt it was much more important to err on the side of doing too much than not doing enough, because we had seen the impact of not doing enough in some countries and not doing enough soon enough. But the absolute critical piece was to do just as much as we needed to, and to make sure that we could stop doing it as soon as we knew what else we could replace it with to keep people safe. And we started very early on looking at, as I mentioned, the unintended consequences. And it is no surprise to me, and Stephen, Dr. Taylor has mentioned it as well, that in this crisis, as in every other crisis, not everybody is affected equally. We know that some children who have been out of school will never make up that time, and that will affect them for the rest of their lives. We know that closing schools for a long period of time affects our community in ways that we may not realize. It is a safe place for many children. We know that we've seen increase in mental health issues. We know we've seen increases in interpartner violence in children who have been affected. We also know that racialized people are more affected by this virus. We know that low-income people are more affected by this virus. And we know that women are differentially affected by the impacts of this pandemic. And I shouldn't say this virus, I should say this pandemic, because it is not just the virus, but it is the impact of the measures that we've put in place to try and make our way through it in this storm. Having said that, we made it through the summer, and our plan, as we were trying to look at how do we get our economy going, how do we make it up for people who have been affected by this virus in ways, and the pandemic response in ways that we have been, that have not yet been determined. How do we get to a place where we have just enough measures to make sure we're not letting this virus spread rapidly so that we're getting exponential growth and again, risking overwhelming our healthcare system and affecting everybody. But how do we make sure that we can get those important parts of our community wellness working again? We know that our community is well when we have people at work, when we have children at school, when we have our healthcare system functioning. So that has been our focus over the last number of months now. And as you know, we've started to see increase in cases again. And we've taken some measures to reduce those areas where we know that the transmission events can happen. I've kept the numbers of people in gatherings to 50, and I'm sorry for that, but it is because that's a number that we wanted to be consistent and have people adapt. And that is the thing that I can see as well, that we have seen so much innovation, we have seen so much adaptation, and we have seen people reach out and connect with family, with friends, with neighbors. And we've appealed to people's altruism. And that is something that is very positive that we've seen in many communities around this province. So where are we now? We need to learn the dance. How do we live with this virus? How do we make sure that we're protecting those who are most vulnerable to severe effects? And for most part, that's our seniors and elders, people with underlying illnesses. But how do we also make sure that we're protecting those who have been differentially affected because they've lost their job, because they've been out of school, because for the other crises that we're dealing with here in British Columbia that has created a dramatic increase in the toxicity of the street drug supply. So people are dying from overdoses in numbers that have been unprecedented in this province. We're in a challenging spot. We're in a very challenging spot. And it's, people are tired. At that 6-month point, for many people, that's where we are with this pandemic. It's easy to get discouraged, to lose hope. And we need to remember that we can make it through and that this is the road we can walk down. We have learned a lot as individuals and communities about how to manage this virus. It is a community virus. It's going to be with us for some time. And we need to keep measures to stop it from spreading wildly in places where we know people are going to be differentially affected until we have a treatment or a vaccine. The positive thing is that there is so much work being done. The global community has come together in ways that we have not seen before in terms of sharing scientific information, and vaccine development is one of those things. And we need to be prepared for that. We need to get through this winter, and we need to do it by standing together as much as we're staying apart. I do believe there's hope. And as Thich Nhat Hanh says, Hope is important because it can make the present moment less difficult to bear. If we believe that tomorrow will be better, we can bear a hardship today. And I think we have many, many reasons to believe that tomorrow will be better, and that we can build on the connections and the bonds that we have made. And we can remember always to do it by being kind, being calm, and being safe.
Thank you so much, Dr. Bonnie Henry, for your candor, your humor, your rigor, for reminding us of our connectedness, both for worse, but definitely for better, and that feeling of kin. I also want to thank you for sharing your own experience of anxiety and sleepless nights and PTSD. We really are all in this together. So thank you so very much. We're very grateful. We're going to move now into the question and answer period. So please use the Q&A feature at the bottom of your screen. Click on the Q&A icon to ask a question to any of our presenters, and please address the question to a specific presenter. Physicians from Lafayette Health Awareness Forum Steering Committee will moderate your questions and then send them to me on your behalf. And I have a question, first of all, for Dr. Stephen Taylor. What do you say to a family member who feels that the COVID threat is a hoax?
That's a really good question. It depends on how strongly they believe this. For some people, they have a hardcore conspiratorial mindset. They'll believe COVID's a hoax. They'll also believe NASA faked the moon landings. They'll believe 9/11 was an inside job. For those people, there's no convincing them. But for someone who strongly believes it's a hoax, if you try and confront them about that, they're just going to generate more arguments to defend their position. So that's not a good way to go. One approach you could do is ask them in a matter-of-fact way, well, what is it that makes you think it is a hoax? And get them to explain it to you, so at least you've got some meeting of the minds. And I would ask the person, well, has there ever been a time where you've doubted it that it was a hoax? What was going on there? And what might it take for you to change your mind about this? I mean, ask the person, are you amenable to changing your mind, or is it fixed? And get them to think about why they might start to take this seriously. But don't confront a person about this.
Engage, don't disengage.
Engage, exactly.
Yeah. Thank you. For Dr. Terry Tam, since most people get mild symptoms with COVID, how about seniors in their 70s? What about seniors in their 70s?
So I think this question is asking, yes, do seniors in their 70s also get mild symptoms? And the answer is definitely yes. I think that COVID can cause mild symptoms in any age group, actually. But we do know that as people get older past the age of 50 and 60, that they do risk getting more severe symptoms. And certainly if they have a lot of comorbidities, other illnesses, diabetes, heart disease, then they also have an increased risk of having more severe symptoms.
Bonnie, do you want to weigh in on that? And by the way, I have been allowed to address all our doctors by their first names.
Yeah, I agree. I think that the thing we need to remember is, a good thing is that children are differentially unaffected by this, which is nice. But there's also some really incredible stories that I know of people. There's somebody I know who was infected in his long-term care home at 101 and survived to his 102nd birthday. A woman who had been traveling in her 80s, she was traveling with her husband and became affected, was in an ICU for 3 weeks and went home and recovered. So we have to remember that even though it most differentially affects older people, and yes, it can be severe and deadly, there's lots we can do now, and when we're not overwhelming our healthcare system and people have the time they need to appropriately prepare and protect themselves, we can look after people really well.
I do have a question for you, Bonnie, and that is when will more family members be allowed to have privileges to visit loved ones in nursing homes?
You know, that is the hardest part of this, because when somebody is in a care home, we know that the staff in the care home are there, and there's a risk that people are going to spread it very quickly between many other people in the care home. And we have seen that happen with tragic results. So that has meant it's been, we're having a hard time finding the right balance. We know how essential it is for people who are older, especially people with dementia, to have that contact with their family, with people they care about or care about them. We're increasing the number of people who work in long-term, particularly care aides, and undervalued, and we need them to be part of that response. So the short answer is we're doing our best. We'll do it as fast as we can. We're recognizing that there's different in who's allowed in and for how long, and we're trying to address that.
Thank you. Just Stephen, how do we help those dear to us whose anxiety is significantly above the current norm?
There are a couple of ways. You can talk with them about it and find out exactly what it is that they're distressed about. We can recommend to them or advise them to limit their amount of news media they consume. Don't get all your news from social media, because that tends to be more sensational. Practice all those good coping strategies that people all know about: getting out, exercise, sleep well, diet. If those things don't work, if connecting with your friends and family, virtually of course, doesn't work, then there are a number of online resources that can help people. And I suggest that people go to our website, which is called coronaphobia.org. And there are a number of tabs there, and there's a section there for consumers or for the public. And you can go down there and you can complete an assessment of the COVID stress syndrome. And there are also a number of links to some very useful websites and phone apps that can help people manage their anxieties.
Thank you very much. Will you say the name of the website again?
Yeah, coronaphobia.org.
Thank you. That's great. Dr. Tam, this is a question that I think is very specific to your experience in the ER. Do you think we will move to rapid antigen testing at the entry to the ER that might let us know if people are infectious? The rapid testing strategy proposed by Michael Mina in the United States, for example, and that might allow us to use PPEs more effectively?
Yeah, that's a great question. Yes, I mean, well, I mean, the first answer is, I believe that rapid testing is we're just on the brink of getting a bunch of these tests. Now, from what I understand, the rapid antigen testing, one of the problems with the rapid testing is that they tend to be quite specific. In other words, if somebody tests positive for COVID, then it's, you know, quite likely they really are positive for COVID. However, the problem is if they test negative for COVID, the test is not as sensitive. And so there's a danger of what we call false negatives. In other words, if they test negative for COVID, we can't really be quite as sure that they don't have COVID. So it remains to be seen how useful that test will be in the ER. I think it's been proposed that, you know, it'll be used possibly for home use or for testing at school. You know, the problem is, of course, if you use it to test for, if you test a patient in the ER and they're negative, and then you send them out and say, well, you know, you're definitely negative, don't self-isolate, there's always this possibility that the test is not actually accurate. So, you know, there probably, I'm sure there's going to be lots of guidelines as to what to do when there's a negative and a positive result. In fact, probably when there's a negative result and you're quite suspicious that the patient might have COVID because they have symptoms, they'll probably need to still go on and have the gold standard test, which we're using right now. So I don't know if it'll help with PPE, actually.
There's another, oh, sorry, go ahead, Bonnie, please.
Yeah, please.
Oh, no, I was just going to agree. I think where they can be really helpful is when we, like the ones that have been approved for use just in the last couple of days, are in more remote communities where access to testing is a challenge, and you have a group of people who are sick. Doing a single test may not give you the absolute answer, but if you have one or two people who are sick and one of them is positive, then you're pretty likely to have it in that community, and you can take the appropriate measures to manage it. So I think but as we get more and more and the technology improves, then there are many different places we can use them.
Another question related to PPEs: can we sterilize N95s using UV light or something similar to allow for more reuse so that healthcare professionals can change them more often?
I can answer that one too, because we've done some really innovative stuff on this. So yes, we've been looking at that. And yes, you can reuse them. With UV sterilization, there's some gas things you can use as well. And we've actually, there's some manufacturers, some companies here in BC, but also across Canada that are doing this. But it is an energy intensive process and it's slow. And you can only do it if the respirators aren't soiled. And one of the things that we're seeing, which is kind of funny in a way, is people getting makeup and lipstick on the inside of the respirator. And so we can't use it if you do that.
Dr. Tam, just a quick last question on PPE. May not be quick at all, but how can we as the public help address the PPE shortage?
I don't have a great question for that, a great answer for that. I don't know how the public can actually help. Maybe, I don't know, maybe Dr. Henry has over to you.
I would say number one is, don't use medical masks and medical respirators in the public. And that's where we, the use of non-medical masks in those settings when you can't maintain your physical distance, really important. And we should all be doing that. When we're in crowded situations, the most benefit comes when you have a lot of community transmission, and that's when we all need to be really adherent to it. But those are important things to do, and make sure that we're keeping the medical masks for the healthcare workers in the health setting.
Yeah, there was, I mean, just exactly, that's a great answer. I mean, if we remember back to March, there was a run, of course, on N95s and 3M respirators. And I remember going on eBay to see what was happening. And I mean, these things were selling on there for, 1,000% markup because people had just bought them all up. So that's a great answer.
Stephen, question about what strategy can be employed to address people, generally younger people, who continue to congregate in large groups?
It's a really important question. I should point out before I answer it, it's not just younger people. There are some older people that do that. It does tend to be younger people, however, and it's only a minority of them. Most younger people are pretty cool with the importance of social distancing. But one approach is to try and understand what are the main reasons, what are the motivations. And for some of these younger people, they're saying, well, we've had important milestones or rituals interrupted. We feel deprived. So for example, they've been unable to attend grad or things like that. So that's important to understand. Some don't seem to understand the seriousness of it. They don't understand that they can be asymptomatic and contagious. So in that sense, public education can be helpful. But I think a variety of different kinds of messages need to be tried, and that's been done already, and I hope they continue to do that. One idea that hasn't been really followed through as much as it could is to identify important people in communities, influencers as they're called, from social media and so forth, to see if you can craft a message that gets across to young people from an influencer or someone who's seen as a younger person in the community with some credibility as to why they should be really careful about not attending parties. Interestingly, we're seeing the opposite, where people organizing drum circles tend to be kind of influencers in the opposite way. So we need to find the other sort, the good influences, to encourage people to not attend large parties and to engage in social distancing.
Apparently, putting a picture with me with a disapproving face on down at Second Beach made a big difference in terms of not attending the drum circle.
That's wonderful. We have so very little time left, and I'm going to do that awful thing that I hear other broadcasters doing, and I'm going to give you each 30 seconds to ask what gives you hope. Dr. Taylor, first of all, Stephen.
What gives me hope is we've been through countless pandemics as a species before, and we'll survive this one. And as Bonnie pointed out, we are innovative and adaptive, and that's why we've overrun the planet like cockroaches, because we are so innovative and adaptive. And so we will get through this, and I'm hoping that we'll be stronger and work more as a community to meet the challenges ahead involving climate change. So I think that there's lots of reasons for hope.
Thank you. Terry, what gives you hope?
All the things that Steve said. I think what gives me hope is just, going outside today, 7 months after all this began. And yes, things have changed quite a lot, but in some ways, things haven't changed, or things are opening up. We're getting used to this new reality. And again, this ability, I know we're using the word adaptation a lot, but the fact that you really see it in the public at large, that by and large, people really kind of understand what needs to be done. I believe so anyways. And you can see the success we're having.
Thank you. And I don't see Bonnie up there. We were having some bandwidth issues. There she is. Hi, Bonnie. Bonnie is connecting. Like, I need to give you a play-by-play, but I really do want to hear Bonnie. What gives you hope?
I'm sorry, I got knocked off there for a second. And I did hear what Stephen said. You know what gives me hope is that every day I hear from elders, I hear from children, I hear from young people, and we are resilient. We will find our way. We're resilient, we're adaptable. And you know what, we still have beauty, and we have to remember that. We have art, we have music, and it still touches us. It may not be in the way we want to. We can still go outside and play. We still have connection. We've not lost that. And we will be together again. And this is not forever. It's for a lot longer than many of us ever wanted it to be. But we will get through this. We will be together again.
Thank you all so much, Dr. Terry Tam, Dr. Stephen Taylor, and Dr. Bonnie Henry, for your presentations and your amazing presence. What an honor to have you with us. And it's been a wonderful evening. We've enjoyed being with you as well. And if you've enjoyed this evening, you may be moved to donate to the Lafayette Music and Health Legacy Fund, a newly established fund to support interdisciplinary research, teaching, and community outreach in the area of music and health. Please go to the Lafayette String Quartet website, which is Lafayette String Quartet, all one word, .ca, and you'll be able to find out more. Tomorrow, you're going to receive an email from the Lafayette Health Forum with a survey about your experience of this evening. Your feedback will help plan future events, so it's very valuable. My big takeaway this evening, I think, is that science will lead us out, but the arts will get us through. Thank you so much for joining us. And we're going to close the evening with one more short musical performance. Wonderful to spend this evening with you. On behalf of the Lafayette String Quartet and the Institute on Aging and Lifelong Health at the University of Victoria, thank you for being with us. And now, please welcome back the Lafayette String Quartet.
We would like to thank Shelagh Rogers for your amazing experience and ease as we navigate our new approach for the forum this year. Thank you for your time and willingness to host us.
And thank you to our wonderful speakers. We are so grateful for your leadership, your guidance, and your steady contributions to the well-being of us all. And we are just over the moon that you have shared in the forum this year. Your generosity has allowed us to start on a very exciting endeavor, which is to begin the Lafayette Music and Health Legacy Forum, to which all donations from tonight's event will go.
And we are extremely grateful to our partners at the Institute of Aging and Lifelong Health and to our steering committee for all of their expert help behind the scenes in presenting tonight's forum, and a particular thank you to Leah Potter from the Institute for her tireless work in setting up and running the webinar. We also want to thank Alana Lundgren, our Dean of the Faculty of Fine Arts, for her support for this evening's presentation.
And to all our guests, we are honored that you have chosen to share this evening with us. We hope that next year it may be possible to again meet in person. If not, we'll continue to be creative as we carry on through the pandemic as safely and artfully as we can. We're going to send you off with another short scherzo by Beethoven. The piece is full of cross rhythms and is exuberant. For us, this music seems to tell us that even when there are many conflicting hopes and energies, the end result can still be joyful.